this video, we'll talk about schizophrenia and psychosis. First, let's start off with timelines, which are really important for diagnoses. If someone is having psychotic symptoms such as hallucinations, delusions, disorganized speech, and etc. for more than a day, but it resolves by a month, that means they had a brief psychotic disorder. Now, if they've been having symptoms for more than that time, so a month to 6 months, that's classified as schizophreniform. And then once they've been having symptoms for more than 6 months, then they have schizophrenia. So the positive symptoms of schizophrenia are what you see, right? The hallucinations, whether it's auditory, visual, delusions, and their negative symptoms are more so about like their affect, which is really flat, and they'll have more social withdrawal, things like that. It's important to know if someone's going to have a good prognosis or a bad prognosis. Characteristics that make someone with schizophrenia have a good prognosis are if they're female, if their symptoms started later on in life, if they're an acute onset of their symptoms, which means like everything kind of came on at once, and that if they have mostly positive symptoms and no family history. Indications for bad or poor prognosis are if the patient is male, if the symptom onset was a lot earlier, so maybe in their childhood or teenage years, young adult, if they had a gradual onset of symptoms, so it slowly came on, if they have mostly negative symptoms, and of course if there's family history of schizophrenia, there's more of a poor prognosis for them. Schizophrenia does have a strong genetic component. Many times they'll have a prodromal phase, and that basically means that before they have the whole actual onset of schizophrenia, they'll start to decline in their function. So whether it's like starting to get bad grades in school, starting to become more withdrawn socially, they become more irritable, they'll just decline in their performance overall. And then slowly over time, they're going to start developing the actual psychotic features. So schizophrenia occurs because you have too much dopamine, right? So you want to treat them with first generation or second generation antipsychotics. Second generations are preferred because they have less EPS symptoms. Now, if you have treatment refractory schizophrenia, then you want to give them Clozapine. With Clozapine, it's really important to remember to check their CPC and ANC because it can cause neutropenia and granulocytosis. And in general, schizophrenia and Parkinson's are on a spectrum. Parkinson's is having not enough dopamine, schizophrenia is too much. So if the drugs are severely lowering their dopamine, they can start having Parkinsonian-like side effects. And same with if you are treating someone with Parkinson's and their dopamine levels become too high, they might start exhibiting some psychotic symptoms. Now, the positive and negative symptoms of schizophrenia. So the positive symptoms come from the mesolimbic pathway, and the negative symptoms come from the mesocortical pathway. Other pathways that are good to know are nigrostriatal, which are responsible for the EPS side effects and Parkinsonian-like side effects. Tubuloinfundibular is the prolactin pathway. And sometimes this is unrelated to psychosis and schizophrenia, but I yield to know that basalis nucleus minor, that pathway is responsible for acetylcholine. Locus cerulous is responsible for norepinephrine production, and the raphe nucleus is responsible for serotonin production. Your substantia niagra in your ventral tegmental area is responsible for dopamine production. On head imaging, so for example on a CT, ventricular enlargement and diffuse cortical atrophy is also seen with schizophrenia. So for your first generation antipsychotics, you have your high potency and low potency. High potency, the drugs are listed below. Haloperidol is the most common one that people talk about. And with first generation, it's important to remember that they are more likely to have EPS symptoms, which is why we tend to prescribe second generation first. And EPS symptoms include dystonia, which is a sustained muscle contraction. For example, their neck muscles will stay contracted, so sometimes patients will just present with their neck like this and they won't be able to move it. So dystonia you can treat with benztropine or diphenhydramine, so Benadryl. Blepharospasm is a type of focal dystonia where you have like involuntary eye closure that's triggered by like bright lights. So for that specifically, you can treat botulinum toxin injections. You can also get akathisia, which is restlessness. They'll be pacing, they won't be able to sit still. For akathisia, you can treat with the 3Bs, beta blockers, benzos, benztropine. And then tardive dyskinesia is like the tongue movements or abnormal involuntary facial movements. For tardive dyskinesia, I can't pronounce these drugs, so they're listed below. And first generation drugs are also more responsible for the neuromalignant syndrome, NMS, that occurs with antipsychotics. So the two most common symptoms to look out for are fever and the lead pipe rigidity. They can also have metabolic acidosis and an increased CPK. NMS can occur with any antipsychotics, but it's very common with the first generation. We treat NMS with dantrolene or bromocriptine. So that has to do with the mechanism with the calcium channel. Second generation antipsychotics not only block dopamine, but they also block the 5-HT2A receptor. Second-gen antipsychotics have less risk of EPS, but each of them kind of have their own side effect to look out for. For example, olanzapine causes weight gain, and metabolic side effects, so you want to check their BMI, their fasting glucose, lipids, things like that. Ziprasidone is more commonly going to prolong your QT interval. Risperidone is more likely going to cause prolactinemia. There's a whole separate video about these medications, but those are some quick high-yield ones. For schizophrenia, also, in addition to giving them appropriate medications, family therapy is another adjunctive way to help them to reduce risk of relapse and hospitalization. For some patients, it's harder for them to stay on the medication for various reasons, so giving them a long-acting injectable is the best way to go, so that way the medication stays in their system. So schizoaffective disorder, this is when you have schizophrenia, but also mood symptoms. So the way I remember it, it's schizoaffective, so they are always having baseline schizophrenia or like psychotic symptoms. And then they'll have periods of time where they're going to have like depression or bipolar, but they never have a time where they're only in a manic episode or in a depressive episode without the psychosis. It's also important to have differentials for psychosis because medical conditions can also kind of appear as psychotic symptoms. For example, acute intermittent porphyria that will present with abdominal pain and also some neurological symptoms, but they can also kind of have psychosis features. To diagnose AIP, you want to do a urine porphyrobilinogen. So Wilson's disease is when you have increased levels of copper and decreased levels of ceruloplasmin. It presents with the Kaiser-Fleischer rings in your eye, and this can also have psychotic features. So for this, you can diagnose it with a slit lamp. And then with renal, liver issues, if you're not able to metabolize things, that can cause toxicity and can present with some psychosis. And you always want to rule out substance use as well. For example, like cocaine, amphetamines, any sort of drugs can also present with psychotic features. Steroid use is also a very common trigger for inducing psychosis as well. So a delusion is a fixed false belief. And a delusional disorder is when you have a delusion persistent for at least a month. But it's important to remember that these people with delusions are still living a normal functional life. Like this delusion is not affecting their life or their capability to work, etc. So, for example, erotomanic delusions are when someone believes that someone else is in love with them, but it doesn't affect their ability to function in life.